Hi, welcome back to your prescription for medication education. My name is Yenmi, and I'm a passionate pharmacist, and I'm here to bring you quality information regarding medications and health-related topics, and in the process, expand my own knowledge. Today's topic was actually requested to be by one of my friends, so I hope you do enjoy today's video. Before we look at which cooking oils support cardiometabolic health, it's important for us to define what a fat is and how different types of fat differ chemically. Fats are one of the main types of macronutrients. Essentially, a fat is a triglyceride molecule. Triglycerides, also referred to as triacylglycerol, are the major circulating lipid in the bloodstream. A triglyceride molecule consists of one molecule of glycerol, which is a 3-carbon alcohol, and each of these carbons contains a hydroxyl group, which serves as an attachment point for a fatty acid. A fatty acid consists of a carboxyl group at one end and a long hydrocarbon, which determines the fat's chemical and biological behavior. The fatty acids are linked to glycerol through ester bonds by esterification. The 3 carbons of the glycerol molecule are numbered using the stereospecific numbering system, designated as SN1, SN2, and SN3. The position of the fatty acids on the glycerol backbone determines the physical properties of the fat, which affect absorption, metabolism, and distribution into tissues. The fatty acids themselves have different chain lengths and varying degree of saturation. Saturated fatty chains have no double bonds, meaning the carbon chain has the maximum number of hydrogen atoms attached to every carbon atom. Monounsaturated fatty acids have one double bond, and polyunsaturated fatty acids have multiple double bonds. So why did we go over all of this? Because while all dietary fats share the same basic structure, the type and position of the fatty acid determines whether a fat is stable, beneficial, or potentially harmful for cardiometabolic health. The 4 main types of dietary fats consist of polyunsaturated fatty acids, PUFAs, monounsaturated fatty acids, MUFAs, saturated fats, and trans fats. PUFAs provide the strongest cardioprotection and contain at least 2 or more double bonds. Examples include linoleic acid, which is an omega-6, and alpha-linolenic acid, which is an omega-3. As a side note, the scientific abbreviation for alpha-linolenic acid is 18,3N3. This means alpha-linolenic acid is an 18-carbon fatty acid with 3 double bonds, with the first double bond occurring at the 3rd carbon from the terminal methyl end, or also referred to as the omega end. Replacing saturated fats with PUFAs provides the greatest reduction in LDL cholesterol, total cholesterol, and cardiovascular disease more than replacements with MUFAs. Omega-3 fatty acids may provide some benefits in persons with cystic fibrosis, dementia, and may provide some beneficial effect on cognitive development in children. These fats are usually liquid at room temperature. MUFAs contain a single double bond and also reduce LDL cholesterol while preserving HDL cholesterol when substituted with 4 saturated fats. Saturated fatty acids contain no double bonds and raise both total and LDL cholesterol levels, which increases cardiovascular disease. Saturated fatty acids tend to be solid at room temperature like butter or the fat layers in bacon or beef. Trans fatty acids have the most adverse effects on the cardiovascular system, raising LDL cholesterol while lowering HDL cholesterol, and are strongly associated with increased cardiovascular risk even in small amounts. Naturally occurring unsaturated fatty acids usually have a cis configuration, which is when the hydrogen atoms are bonded to the same side of the carbon-carbon double bond, creating a bend in the fatty acid chain. Trans fatty acids are typically the result of an industrial process called hydrogenation. This process involves adding a hydrogen atom to the unsaturated oils but creates trans double bonds in this process. These hydrogen atoms are attached on the opposite sides of the carbon-carbon double bond, creating a linear shape resembling a saturated fatty acid. Fortunately, the US banned artificial trans fats because they were ruled unsafe in 2015 and required all manufactured trans fats to be eliminated from the US food supply in 2021. However, foods can still be sold legally if they contain a half gram of trans fat or less per serving and may still be labeled as containing 0 grams of trans fat. Liquid plant oils high in unsaturated fats support cardiometabolic health and are recommended over saturated fat-rich tropical oils and animal fats. The American Heart Association recommends using non-tropical liquid plant oils in the place of saturated and trans fats. Olive oil and canola oil have the most evidence. Extra virgin olive oil is rich in polyphenols which act as antioxidants, helping to protect cells from damage and reduce inflammation. Canola oil is high in both monounsaturated fats and alpha-linolenic acid. Other beneficial oils include corn, safflower, sunflower, and soybean oils, which are rich in PUFAs when used in the place of saturated fats. The PREDIMED trial remains the only major randomized control trial demonstrating that a specific oil, extra virgin olive oil, reduces hard cardiovascular endpoints. The PREDIMED trial demonstrated that a Mediterranean diet supplemented with extra virgin olive oil reduced major cardiovascular events by approximately 30%, including a 35% reduction in stroke. In the United States, soybean oil is the most commonly used cooking oil, followed by canola oil, corn oil, and olive oil. Soybean oil dominates because it is widely used in processed and packaged foods. In a 24-year prospective study of over 500,000 adults, each tablespoon per day of soybean oil was associated with a 15 to 20% lower total mortality when substituted for butter. Tropical oils high in saturated fats include coconut and palm oil. Coconut oil raises both LDL and HDL with no clear cardiometabolic benefit. Meta-analysis show coconut oil increases LDL by about 10 milligrams per deciliter and HDL by about 4 milligrams per deciliter compared to non-tropical vegetable oils. Coconut oil consumption shows no significant effects on body weight, waist circumference, triglycerides, glucose control, or inflammatory markers. The American Heart Association recommends limiting coconut oil due to its high saturated fat content and lack of proven cardiovascular benefits. This table highlights some of the differences between the tropical oils like coconut and palm oil, which are high in saturated fat, and tropical liquid plant oils like olive oil and canola oil, which are rich in monounsaturated fats. Soybean, corn, and safflower oils are also high in PUFAs. And flaxseed oil is the richest plant source of omega-3 fatty acid amongst the commonly consumed oils. You might read on the internet by critics that oils such as canola, soybean, corn, and sunflower oil are linked to inflammation and chronic diseases due to their refining process, which increases the omega-6 to omega-3 ratio. The refining process, which includes deglumming, bleaching, and deodorization, does remove some essential nutrients and can generate undesirable trace compounds such as 3-MCPD esters and glycidyl esters under high heat. Clinical trials consistently show that increased omega-6 intake while keeping omega-3 unchanged does not increase markers of inflammation or oxidative stress, contradicting common concerns about refined seed oils. No long-term randomized controlled trials or prospective cohort studies have directly compared refined seed oils versus cold-pressed seed oils for hard cardiovascular outcomes, cancer incidence, or all-cause mortality in humans. The existing evidence is limited to short-term trials measuring surrogate markers. The evidence supports that the type of fat matters more than the degree of processing. Replacing saturated fats with these refined vegetable oils, despite their processing, consistently demonstrates cardiovascular benefits through LDL reduction and lower mortality risk. The adverse effects reported in some studies relate to the repeated heated oils, not to the refining process itself. When vegetable oils, especially those rich in PUFAs, are exposed to prolonged or repeated heating, such as deep frying, several harmful chemical changes occur. Human evidence is limited, and most of the data comes from animal studies. Animal studies consistently demonstrate that consumption of repeatedly heated oils causes metabolic dysregulation, inflammation, and genotoxic effects. Thermal stressing of PUFA-rich oils generates high levels of cytotoxic products, including genotoxic and cytotoxic alpha-beta unsaturated aldehydes. These compounds can be associated with health risks, including cancer, Alzheimer's, and Parkinson's disease. Repeatedly heated cooking oils generate polycyclic aromatic hydrocarbons, some of which are carcinogenic. Analysis of repeatedly boiled sunflower oil showed higher amounts of known carcinogenic and mutagenic polycyclic aromatic hydrocarbons compared to fresh or single boiled oil. Reviews conclude that consumption of repeatedly heated cooking oil and inhalation of cooking fumes have been associated with increased incidence of lung, colorectal, breast, and prostate cancers, though these associations come primarily from observational studies with significant confounding factors. The type of oil matters significantly. Oils higher in polyunsaturated fats, such as soybean, corn, and sunflower, are more susceptible to oxidative degradation during heating than those higher in monounsaturated fats, such as olive oil, or saturated fats like palm oil. This evidence supports using fresh oils for each cooking session and avoiding reuse of frying oils, particularly for PUFA-rich seed oils. However, it's important to note that the robust cardiovascular benefits observed in human studies of fresh refined seed oils discussed earlier far outweigh theoretical concerns, and the priority remains replacing saturated fats with unsaturated fat sources. Okay, so to wrap things up, linoleic acid and alpha-linolenic acid are essential fatty acids, meaning our bodies cannot make them on their own and we must get them from the diet. These omega-6 and omega-3 fats are precursors to important signaling molecules called eicosanoids, which regulate inflammation, platelet function, and vascular tone. Linoleic acid is converted to arachidonic acid, while alpha-linolenic acid is converted inefficiently into EPA and DHA. DHA is especially important for brain and eye development. When it comes to cardiovascular disease, studies show that EPA and DHA modestly reduce the risk of myocardial infarction and coronary heart disease, but they have little or no effect on total cardiovascular events, stroke, or all-cause mortality. The 2025 American College of Cardiology scientific statement recognizes these limited benefits and also notes that EPA alone may be more effective than EPA plus DHA, while also highlighting a dose-dependent increase in atrial fibrillation risk at higher doses. The strongest evidence for cardiovascular benefit comes from prescription-grade purified EPA, specifically icosapent ethyl at 4 grams per day in high-risk statin-treated patients with elevated triglycerides. These benefits cannot be extrapolated to over-the-counter fish oil supplements. Large trials using typical OTC doses, usually 1 gram per day or less, of EPA plus DHA, have consistently shown no cardiovascular benefits. That does not mean that OTC fish oil have no role. These products can lower triglycerides in a dose-dependent manner, typically by about 15%, but clinically meaningful triglyceride reduction usually requires at least 2 grams per day of combined EPA and DHA, a dose that most over-the-counter products do not provide. DHA also remains important for brain and eye health, as I mentioned earlier, particularly during early developments. Their primary evidence-based role for OTC fish oil is limited triglyceride lowering and omega-3 supplementation, while meaningful cardiovascular risk reduction is supported only for prescription-grade high-dose EPA in carefully selected high-risk patients. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing and sharing my channel. It would mean a great deal to me. And as always, thank you. Have a great day.